for Kanun Ki Pathshala. Special regards to Dr. Kohli and Dr. Gaurav and my colleagues. Uh, I'm bringing a problem today, a mother brought dead, a clinical, medico-legal, and ethical approach for gynecologists. The term mother brought dead describes an unfortunate and a complex situation where a pregnant or a postpartum woman is brought to a healthcare facility with no signs of life. Managing such cases requires a systematic, multidisciplinary approach that includes immediate clinical assessment, potential resuscitation, medico-legal documentation, and compassionate communication with the family. In obstetrics, two life matter. In obstetrics, these cases are particularly challenging because two life matter, the mother and the fetus demanding urgent and well-coordinated action. Furthermore, the legal and the ethical implications surrounding maternal deaths necessitate detailed documentation and often an autopsy, especially when the cause of death is unclear or suspicious. This presentation of mine outlines a structured approach to handling these critical cases efficiently. I would like Dr. Gaurav and Dr. Kohli to make a critical comment as far as my presentation is concerned. The factors responsible for cardiac arrest in pregnant women are broadly described as cardiac causes, non-cardiac causes, and American Heart Association also have put up a list. In cardiac causes, they can be congenital heart disease, vascular disease, cardiomyopathy, and others. Non-cardiac causes we are used to hearing it day in, day out: hemorrhage, sepsis, eclampsia, anemia, which my colleague Dr. Ila is going to present, pulmonary embolism, and American Heart Association has also described bleeding or disseminated coagulation, embolism, maybe coronary, pulmonary amniotic fluid, anesthetic complications, uterine atony, cardiac diseases, hypertension. In others, they have said 4H and 4Ts. H stands for hypoxia, hypovolemia, acidosis, hypothermia, hypo and hyperkalemia. T stands for tension pneumothorax, toxins, coronary thrombosis, pulmonary thrombosis, and cardiac tamponade. Now, brought dead case handling by gynecologists, what all it entails. Ensure a complete case documentation, right from the name, age, LMP, EDD, last visits, what had been our complaints, sign of life, and the time of arrival must be noted legibly. Declare dead only after protocol. Follow standard death declaration with two senior doctors confirming absence of maternal and fetal heart sounds. Medico-legal case notification. Every brought dead at 37 weeks must be registered as an MLC and a police must be informed. Postmortem must be requested. For any unexplained maternal death, write in the file that the consent sought for autopsy and postmortem to determine the exact cause. Talk to the family clearly and empathetically. Avoid medical jargon. Ensure in a very simple language the senior doctor should communicate to them. Document the conversation in medical records. For Hospital Risk Management Committee, review each brought dead case, create a root cause analysis, and implement action points. Case scenario: a 32 years old unbooked pregnant patient at 37 weeks is brought to the emergency department by her husband in an unresponsive state. Her family reports a collapse at home. On arrival, her vital signs are as follows. There was no pulse, there was no respiration, fixed dilated pupils were there, ECG showed asystole, blood pressure was not recordable, fetal heart sound was all absent, physical examination showed bruises on the arms, scratch marks present on the neck. Now, what are the challenges in this case? Given the sudden and the unexplained nature of the maternal death, along with possible sign of physical trauma, an urgent clinical and a medical legal response is warranted, particularly considering the possibility of domestic violence. Now, stepwise management of the mother's broad dead is immediate history from the accompanying person, reviewing referral slip if there is any, see the investigation in the past, clinical assessment and the confirmation of death both of the mother as well as of the baby. A structured evidence-based approach is crucial upon arrival. The primary survey is done for three things: airway, breathing, and circulation, ABC. Assess the patency of the airway. Observe for spontaneous breathing for at least 30 seconds. After this, palpate for the carotid and the femoral pulses, minimum for 10 seconds. Examine pupils which are fixed. Dilated pupils suggest brainstem failure. ECG to confirm asystole in 2 leads to declare death. If pulseless electric activity is noted, investigate for reversible causes, and if you find ventricular fibrillation, ventricular tachycardia is detected, attempt defibrillation. Point of care ultrasound, which is again new to me, that if you find the mother dead and the fetal heart activity is not there, this point of care ultrasound should also be done to assess the cardiac activity to confirm the absence of the heartbeat. Check the inferior vena cava for any trauma-related findings. Evaluate the fetal heart activity, that is, absence confirms intrauterine fetal demise. So the key decisions are here. If the death is confirmed, proceed to step 3. If any signs of life are present, continue with step 2, that is for resuscitation. Step 2 is advanced resuscitation if indicated. If resuscitation is warranted, follow ACLS protocols, intubate the patient, secure an IV lines, administer epinephrine 1 milligram every 3 to 5 minutes. Now this is a logarithm which I have brought it, not very relevant for the case, but at the same time one must know about it. If you find that the cardiac arrest has, the woman is brought with a cardiac arrest, chest compressions, call for help, all simultaneously, and displace this uterus to the left lateral position. Ensure ventilation, firstly via bag and mask. Intubation can be considered if a skilled provider is present. Defibrillator is only used when you find there's a ventricular fibrillation or ventricular tachycardia, and otherwise proceed with postmortem cesarean section, that is hysterotomy, within 4 minutes, maximum of 5 minutes of the cardiac arrest, irrespective of the rhythm. If roughly you find out if the fundal height is more than umbilicus, then you assume it to be 24 weeks and things have to be done. If asystole is there, then the pulsar selectivity is noted. You can give a shot of repeated shots of epinephrine. Resuscitative hysterotomy is considered if the pregnancy is for over 24 weeks, and 4 minutes rule is if maternal resuscitation, it is only for the mother's sake this hysterotomy is done. If maternal resuscitation does not show improvement after 4 minutes, initiate resuscitative hysterotomy. Establishing the cause of death. Determining the cause of death is critical, both for clinical insight and for legal accuracy. An autopsy must be advised in all cases of if the mother is brought dead for exact cause of death. Step 4 is all brought dead cases hold legal significance. Obstetricians must adhere to the standardized medical legal protocol, which includes mandatory reporting. Any woman brought dead, the mother must be reported, it must be reported to the police and the medical legal team. Thorough documentation must be made, a medical legal report is prepared, record the arrival time, clinical findings, ECG confirmation, injuries, interventions, and the history given by the family. Evidence preservation, if the trauma, poisoning, and the foul play is suspected, preserve clothing and other evidence like urine, blood sample, and hand over to the police. Death certification, no death certificate is issued by the attending doctor. Autopsy is to be advised in all cases for exact cause of death. If the relatives decline autopsy, the same must be recorded in the medical legal register along with the details of the police constable who is present, that you have informed him that the postmortem you want it, it is a mandatory in this particular case. And then it is left whether what the police does. It must be recorded. This, and in the record when you made of the police constable, his name and the belt number must be also documented in the file. As for the social and ethical considerations are concerned, you must communicate with the family. Senior person should compassionately do this job, avoiding technical jargon. Explain why the autopsy may be necessary while considering cultural sensitivities. Ethical challenges, maternal versus fetal survival, always prioritize mother, mother, and mother only. Religious and cultural resistance to autopsy you may encounter, address concerns sensitively, but adhere to the legal requirements, that is, post-mortem is necessary. Suspicion of domestic violence, it is both an ethical and a legal duty to report suspected abuse. So in conclusion, managing mothers brought dead cases requires a well-structured, multidisciplinary approach. Obstetricians must be clinically skilled and legally informed and ethically sound in their approach. This is essential for protecting the attending doctor against medical legal litigations and for felicitating justice to the mother in case of the foul play has taken place. Key messages are: confirm maternal death by clinical assessment, by ECG and ultrasound, never assume death on arrival. Follow ACLS and promote and consider resuscitative hysterotomy within 4 minutes if the pregnancy is more than 24 weeks. Detailed documentation and a prompt medical legal reporting is essential. Communicate with family very empathetically. Please mute yourself. Thank you very much.